Critical congenital heart defect screening. It is essential that critical congenital heart defects, CCHDs, be identified early after birth to prevent injury or death to infants. The AAP recommends pulse oximetry as a part of normal screening for all infants before discharge from the birth facility. The screening should be done on the right hand and either foot with motion-tolerant oximeters after the first 24 hours of life. An oximetry reading of 95% or less in either extremity or 3% or more absolute difference between the upper and lower extremity requires further testing. Hearing screening. Approximately 12,000 infants are born in the United States each year with hearing impairment. It is the most common congenital abnormality in newborns. Because early detection and treatment can prevent or reduce developmental delays and help the child communicate better, auditory screening of all newborns within the first month is recommended. Infants who do not pass these screenings should be rescreened, and if they still do not pass, they should have audiologic and medical evaluations by no later than 3 months of age. A goal of Healthy People 2020 is to increase the proportion of newborns who are screened for hearing impairment by age 1 month, have audiologic evaluation by age 3 months, and are enrolled in appropriate intervention services by age 6 months. To accomplish this goal, a screening test is usually given to infants before discharge from the birth facility. Otoacoustic emissions and acoustic brainstem response tests are used for screening. The tests can be done while the infant sleeps. The nurse ensures that infants receive screening and explains the testing to the parents. An infant who fails the first screening is often retested in the birth facility. Parents of infants referred for further testing after discharge need more explanation and emotional support. Other screening tests. Blood tests to screen for metabolic, hematologic, or genetic disorders are also performed. With early identification and treatments, infants with these conditions may avoid severe intellectual disability or other serious problems. Common disorders often included are Phenylketonuria, PKU, hypothyroidism, Galactosemia, hemoglobinopathies such as sickle cell disease and thalassemia, and congenital adrenal hyperplasia. Screening tests are easy and inexpensive. They require a blood sample taken from the infant's heel, and only one blood sample is needed for all the tests. The tests are performed at 24 to 48 hours after birth. Further testing is necessary to confirm any abnormal test results. Parents may have questions for the nurse about the purpose of the tests. A pamphlet with information about the tests may be given to parents. Nurses often refer to the tests as PKU tests, but they should call them screening tests, instead to emphasize that a number of conditions are included. Tests performed within the first 24 hours of life are less sensitive than those performed after 24 hours. Infants tested before age 12 to 24 hours should have repeat tests at age 1 to 2 weeks, so disorders are not missed because testing was done too early. Commonly screened conditions. Phenylketonuria. PKU is a genetic condition in which the infant cannot metabolize the amino acid phenylalanine, which is common in protein foods such as milk. Although some phenylalanine is essential to growth, accumulations of it can result in severe intellectual disability. Treatment should be started by the 3rd week of life. PKU is treated with a special low phenylalanine diet, in which the amount of the amino acid is carefully regulated. Congenital hypothyroidism. Congenital hypothyroidism occurs when the thyroid does not produce enough thyroid hormones, which affect the entire body. Symptoms in an untreated infant include a hoarse cry, large fontanelle and tongue, slow reflexes, abdominal distension, lethargy, and feeding problems, and can lead to intellectual disability. Infants may have no signs in the early weeks, but early treatment with thyroid hormones is necessary to ensure normal growth and intellectual function. Galactosemia. Absence of the enzyme necessary for the conversion of the milk sugar galactose to glucose causes galactosemia. The condition results in damage to the liver, increased susceptibility to infection, intellectual disability, and other developmental problems. Treatment includes a diet free of lactose and galactose. Long-term complications such as delayed growth and neurologic impairment may occur even with treatment. Hemoglobinopathies. Hemoglobinopathies include sickle cell anemia, thalassemia, and other disorders. The conditions are most often found in infants of African, Mediterranean, Indian, or South and Central American background. The hemoglobinopathies cause chronic anemias, sepsis, and other serious conditions. Congenital adrenal hyperplasia. The term congenital adrenal hyperplasia refers to a group of disorders with an enzyme defect that prevents adequate adrenal corticosteroid and aldosterone production and increases production of androgens. Infants may have ambiguous genitalia, or masculinization of female infants at birth. Salt wasting crisis with low sodium and glucose and high potassium levels may occur within the first week of life. Treatment is administration of corticosteroids and mineralocorticoids for the remainder of the child's life. Other conditions. Screening also may be performed for maple syrup urine disease, biotinidase deficiency, homocystinuria, cystic fibrosis, and other conditions. Each of these conditions can be accurately diagnosed in newborns, so treatment can begin early. Knowing that many conditions are included in testing allows the nurse to explain its importance to the parents. Discharge and newborn follow-up care. Discharge. Although state and federal legislation allows women and infants to stay in the birth facility for 48 hours after vaginal birth and 96 hours after cesarean birth, some women choose to go home earlier. The time of discharge varies according to the wishes and needs of the mother and the primary caregiver's assessment of conditions of the mother and baby. Discharge is considered when term newborns who are appropriate for gestational age have normal physical examination results and show that they are making the transition from fetal to neonatal life without difficulty. Infants should have normal stable vital signs for the 12 hours before discharge, have fed successfully at least twice, passed urine and stool, and have no excessive bleeding at the circumcision site for at least 2 hours. Newborn laboratory and screening tests and evaluation for sepsis should have been completed. Hepatitis B vaccine should have been given or plans for administration made. If infants have significant jaundice, plans for follow-up after discharge should be made or the infant's discharge may be delayed. The mother should have received teaching about infant care and should demonstrate knowledge, ability, and confidence to provide adequate care to the newborn. An appropriate infant car seat should be available at discharge. Family, environmental, and social risk factors should have been assessed and plans made to safeguard the infant as necessary. The family should have an adequate support system and have plans for continued care from a healthcare provider. Follow-up care. Care after discharge from the birth facility is very important. The AAP recommends that follow-up by a healthcare professional be provided within 48 hours for all newborns who are taken home from the birth facility less than 48 hours after birth. This care can be provided in the home, clinic, or office. Any infant who is breastfeeding or has risk factors should be seen within the first week and usually within 2 to 3 days of discharge. Home care of the infant. In the birth facility, parents often receive more information about care of the newborn than they can absorb. This may leave them inadequately prepared to cope with the multiple demands of early parenting. Family members, once the primary source of support for new parents, frequently live far away, and parents must rely on friends, healthcare personnel, childcare classes, television, books, magazines, and the internet for information. Nurses are ideal sources of assistance in these situations and can also help parents evaluate the validity of information they receive from non professional sources. Care after discharge. Various programs have been instituted to provide after discharge care for mothers and infants. They may include parenting and childbirth classes, or nursing contact with the family in the home, in the clinic, or by telephone. Home visits. The home visit is ideally scheduled during the first 24 to 72 hours after discharge. This timing allows early assessment and interventions for problems in nutrition, jaundice, newborn adaptation, and parent-infant interaction. Nurses may visit low-risk mothers and infants or may follow high-risk infants after discharge from the neonatal intensive care nursery. Visits usually are 60 to 90 minutes to allow enough time for assessment and teaching. Home visits are expensive and are not available in all areas, but they do provide the most comprehensive care. Visits to low-risk families. During the home visit, the nurse performs a physical examination of the mother and infant. Family adaptation to the addition of a new member and the adequacy of the mother's support system is also assessed. Reinforcement of the teaching that was begun at the birth facility is important. A feeding session should be observed, especially if the mother is breastfeeding. The nurse may take blood for metabolic screening if the infant went home too early to have had reliable testing in the birth facility. Safety in the home is often discussed, and questions about infant care and general parenting are answered. Home visits provide reassurance for parents and may increase a woman's confidence and competence in caring for herself and her infant. The visits are especially valuable in recognizing jaundice and intervening before bilirubin levels become dangerously high. When jaundice is found, the nurse can discuss the implications and check the transcutaneous bilirubin level or draw blood for testing serum bilirubin levels. Appropriate care, including hydration and phototherapy, is discussed as necessary. Feeding is an area of concern for many mothers, especially if they are breastfeeding. When the nurse helps a woman cope with problems, the infant's intake may increase. Increased intake leads to greater bilirubin excretion, which may help avoid the need for phototherapy. Visits to families with high-risk infants. High-risk infants often need special care after discharge. Parents may be very anxious about assuming the care of an infant who has had a prolonged hospitalization. Many hospitals have programs that enable parents to take over their infant's care gradually before discharge. A nurse may visit the home before the infant's discharge to help the family plan for accommodating the equipment and the type of care the infant needs. The home is checked for the availability of electricity, heat, and a telephone. If the family has a technology-dependent infant, the nurse checks that they have notified the utility companies and have battery backup to ensure that no disruption of services occurs. After the infant is discharged, nursing visits can help the family maintain the infant's health and decrease the need for rehospitalization. Components of each visit vary according to the infant's needs. The nurse provides assessment of the infant and the parent's caregiving ability in addition to necessary teaching and nursing care. Medically fragile infants may require home treatment with mechanical ventilation, oxygen therapy, or apnea monitors. Parents may have to perform such nursing skills as tracheostomy care, tube feedings, suctioning, and care of intravenous sites. Mothers often have concerns about feeding the infant, which may differ greatly from feeding a healthy, full-term infant. Follow-up telephone calls from nurses between visits help families adapt to the needs of these infants and may also decrease the need for rehospitalization. Infants with complications often need more frequent visits to the pediatrician or nurse practitioner or are re-hospitalized during the early months after birth. Common problems include respiratory illness, infections, gastroenteritis, sepsis, urinary tract infections, otitis media, and need for surgery. These parents need information on preventative measures and care of the infant with an acute illness. General considerations in home visits. The nurse making a home visit is a guest of the family and should adapt nursing care to the home setting. The needs of other family members should be considered. Careful planning before the visit is essential. The nurse calls to schedule the visit at a time convenient for the family. Setting priorities based on the needs identified by the nurse and the family is important. Strong communication skills and the ability to quickly develop rapport facilitates accomplishment of mutual goals. A brief social interaction may be beneficial at the beginning of the visit to develop a trusting relationship. The purpose of the visit should be explained and the family's expectations and desires discussed. The nurse should be aware of any cultural practices affecting the family's view of care. In patriarchal cultures, the father is the head of the family, and teaching should be performed through him. In some cultures, one or both grandmothers are important influences in the care of the mother and the infant. After the visit, additional visits may be planned, or the family may be given a telephone number to call to receive further help if needed. The results of the assessments, teaching, nursing care, referrals, and plans for follow-up should be recorded. Copies of the record usually are sent to the primary caregiver. If problems are identified that need to be discussed with the primary care provider, a report is made by telephone. Outpatient visits. Outpatient visits may be provided in a pediatrician's office or in a birth facility clinic. Assessment and care are essentially the same as those provided for home visits. A feeding session is often observed for the lactating mother, so the nurse may offer assistance. The advantage of outpatient visits is that the nurse does not have to travel to the home and can see more patients each day, thereby reducing the cost of the service. Assessment of the home setting and family interaction, however, is not possible. Clinic visits usually last 30 to 45 minutes. Telephone counseling may be provided during follow-up calls to discharged patients or when parents call warm lines for help with problems or questions. The major disadvantage is that the nurse cannot perform an in-person assessment of the mother, baby, or home environment and must rely on the caller to present an accurate picture of the situation. Follow-up calls. Follow-up calls are placed by nurses in the first few days after discharge. The nurse asks a series of questions to assess the physical condition of the mother and infant to identify any needs or problems. All mothers may receive calls or only those considered at risk for problems. If problems are discovered, the nurse may schedule another call or a home visit or refer the woman to her primary care provider. Warm lines. Warm lines, also called helplines or information lines, provide parents with an opportunity to ask a nurse questions arising from the daily challenges of parenting. Warm lines are used for troubling but not emergency situations. The service should be available 24 hours a day and should be staffed by qualified nurses. Parents often call about infant feeding, breastfeeding concerns, postpartum blues, and basic care of the mother and infant. Calls last about 15 to 20 minutes. The nurse answers the caller's questions and assesses for other problems. The nurse may call back later to find out if the issue has been resolved. Telephone techniques. Nurses caring for patients by telephone should understand telephone counseling techniques. They need special education in telephone communication and triage. Telephone triage involves determining the existence of and solution to a serious problem. The nurse should be skilled at soliciting information to identify problems and determining the priority of the problem identified. The nurse should help the caller describe the major concerns, which may not be those discussed first. What worries you most may help the caller focus on the most important problems. Although most problems discussed are concerns about normal infants, the nurse should be alert for red flags that signal serious situations needing immediate referral. The patient should be allowed enough time to avoid feeling hurried. Lay terminology should be used and questions asked to elicit detailed description of the problems. Parents should be reassured that their questions are valued so they do not feel hesitant to ask what they may see as a silly question. Guidelines and documentation. When nurses give care by telephone, they should have written protocols and policies that provide guidelines for care to ensure that all who perform this service provide patients with similar information. A list of common questions can be compiled to help nurses give appropriate information when parents call about a problem. Parents should always be told when and how to seek more care if problems are not resolved. If the infant seems ill, referral to the pediatrician or hospital emergency department is most appropriate. The nurse's judgment, based on education, expertise, and experience, determines how helpful the service is to patients. All calls should be documented so that accurate records are available for future reference. The nurse may use a checklist or a simple written description of the call. Documentation should include identifying information for the caller, reason for the call, problems described, advice given, and any referrals given. A copy of the information is sent to the primary caregiver to provide continuity of care. Infant equipment. Generally, parents obtain most of their baby equipment before the infant is born, but nurses may receive questions in the weeks after the birth. Although nurses should not recommend specific brand names of equipment, their guidance about features and safety is helpful. Safety considerations. Parents, especially those of limited means, need to understand that few, if any, pieces of equipment are absolutely essential for newborns. Infants sleep in padded dresser drawers and designer cribs with equal comfort. Safety is the most important consideration. New equipment sold in the United States is generally safe because manufacturers are required to follow certain governmental standards for safety. A ruling by the U.S. Consumer Protection Safety Commission banned the sale of cribs with a side rail that drops down. Other changes included in the ruling have made cribs more durable and safer for infants. Hand-me-down equipment may have been recalled by the manufacturer for safety defects. Parents can check with the Consumer Product Safety Commission for a list of recalled products. Older equipment should be checked carefully to ensure all parts are strong and working properly. All nuts, screws, bolts, and hooks should be checked periodically to ensure that they are tight. Car safety seats. Child safety seats for cars are essential to reduce injury and death to infants and children when accidents occur. An infant carried by an adult while in a car is never safe. Legislation has been passed in all 50 states requiring restraint of infants and young children in car seats when they are riding in automobiles. Laws vary with regard to when and at what weight or height an infant or child can move from one type of car seat to another. The AAP had earlier recommended that infants be placed in a rear-facing seat until 12 months of age. The current recommendation is that rear-facing seats be used for infants until they are 2 years of age or have reached the highest weight or height allowed by the car seat manufacturer. Discharge teaching should include information about state car seat laws and the change in the age at which infants can move to a forward-facing seat. Infants should be placed in a rear-facing car seat when they are discharged from the hospital. The seat should recline at approximately a 45-degree angle. Car seats should be installed per vehicle and car seat manufacturer instructions. Helpful information from the AAP is available. Preterm and small infants may need special adaptations. Blankets or bolsters placed at the head, along the sides, and between the legs may improve the fit. Blankets and bolsters should not be placed under the infant. Some infants have low oxygen levels, bradycardia, or apnea when in a car seat. Facilities often have parents or infants who are less than 37 weeks of gestation or low birth weight bring their car seat to the hospital to test the infant's response to being placed in the seat. During testing, the infant's vital signs and oxygen level are monitored. Infants who have respiratory compromise in car seats may need to use special seats or beds designed specifically for preterm or low birth weight infants. In many agencies, nurses are not allowed to install car seats for parents. Some agencies have technicians on site who have special training to help parents determine whether car seats are correctly installed. Car seat fitting stations are available in some areas to determine whether car seats are used properly and to provide teaching for parents. A list of such stations is available. Further information about proper use of car seats, recall of car seats, and a rating system of car seat brands is available on the internet from sources. Early problems. Crying. Crying is a major parental concern during the early weeks after birth. Crying peaks at approximately 6 weeks of age at up to 3 hours a day. It usually decreases to 1 hour or less each day by 3 months. Crying is most frustrating to parents when they cannot find the cause for it. Infants cry for many reasons, including hunger, discomfort, fatigue, overstimulation, and boredom. Parents often can identify the problem on the basis of the type of sound made during crying. Sometimes no specific cause can be determined. When the cause for crying is not obvious, some parents are afraid that responding may spoil the infant. If the infant stops crying when picked up, their concern may increase. However, changing the infant's position may help gas move in the intestines, relieve tired muscles, or distract the infant by changing the scenery, bringing about a temporary end of crying. Infants cannot signal that they have unmet needs in any other way but by crying, and are not spoiled when parents meet their needs. In fact, their needs should be met in a consistent, warm, and prompt manner for development of trust to occur. Infants who are consistently held when in distress cry less at 1 year and are less aggressive at 2 years of age. Therefore, parents should be taught the importance of consistently and quickly answering infant cries. Some families develop creative methods for dealing with crying infants. Others benefit from a nurse's suggestions about appropriate techniques to use. Colic. Description. Colic is characterized by irritable crying for no obvious reason for 3 hours or more a day. It usually takes place during the late afternoon or evening on at least 3 days a week, lasting at least 3 weeks. It occurs in 10 to 20% of infants under 3 months of age. Colic begins at 2 to 3 weeks, peaks at 6 to 8 weeks, and ends up to 3 to 4 months of age. Some infants continue to have colic until 6 months of age. The infant is in good health, eats well, and gains weight appropriately despite the daily crying episodes. Both breastfed and formula-fed infants have colic. Infants with colic cry as though in pain, draw their knees onto the abdomen or rigidly extend the legs, and may pass flatus. The crying is intense and may last until the infant falls asleep, exhausted. Because crying causes so much parental distress and may interfere with bonding or be a factor in parenting disorders or child abuse, nurses should find ways to provide support to parents of infants with colic. Although many theories have been investigated, the cause of colic remains unknown. Allergies to cow's milk or to substances in the breastfeeding mother's diet, abnormal intestinal peristalsis, gastrointestinal tract or nervous system immaturity, feeding techniques such as overfeeding, and parental stress have all been considered. The cause is probably a combination of factors. Actual disease states should be ruled out before a diagnosis of colic can be made. Interventions. Nursing interventions include using therapeutic communication to help parents express their frustrations and teaching techniques for coping with the problem. Parents should be encouraged to talk about their feelings and should be reassured that colic is temporary and does not indicate poor parenting. They often feel inadequate because of their failure to manage the problem and guilty if their frustration develops into anger. The nurse should explain that it is not abnormal to have ambivalent feelings or even anger toward the infant. It is essential to take time away from infant care to rest and recoup energy needed to cope with the demands of a crying infant. Parents should leave the infant with a babysitter for short periods or take turns consoling the infant to provide breaks from the crying. The techniques listed in patient teaching methods to relieve crying in infants may temporarily alleviate crying caused by colic, but generally no technique gives prolonged relief. Feeding the infant in an upright position and burping frequently may help relieve discomfort caused by swallowed air. Use of the 5 S's technique may be helpful. Chamomile tea is often given to infants because it has an antispasmodic effect. Any herbs the parents are using should be checked with the healthcare provider to ensure that they are safe. Simethicone, an anti-flatulent, has not been found effective, although some parents have reported that it helps. A quiet environment, a calm approach, and a fairly regular schedule may help some infants with colic. Increasing the time spent carrying the infant often results in some improvement. Parents should be assured that spoiling does not result from responding to the infant's cries. One possible result of crying in infants is abusive head trauma, formerly known as shaken baby syndrome. AHT results from blunt trauma or shaking an infant vigorously enough to cause the soft tissue of the brain to bounce against the skull. Subdural or subarachnoid hemorrhage, retinal hemorrhage or detachment, skull and other fractures, and damage to the spinal cord may result. The infant may show little sign of external trauma. AHT is the leading cause of death from child abuse in the United States. It causes death in 25% of babies who are shaken violently. The primary cause of AHT is inconsolable crying in an infant, usually 4 months of age or less. Nurses can help prevent AHT by making parents aware of the danger in shaking infants and by helping parents learn methods to cope with infant crying and their own anger that may result from it. Parents are encouraged to share information about the dangers of AHT with other caregivers. Birth facilities often include pamphlets and other information on AHT with discharge teaching. Various educational programs have been held in hospitals, middle and high schools, daycare facilities, and other community centers to increase the public awareness of the problem. Further information on AHT may be found at internet sites. Sleep. Parents. During the early months after birth, parents often wonder whether they will ever get a full night's sleep again. Because they are so often up during the night, they should try to make up for lost sleep at other times. If the mother is not employed, she may be able to sleep during the day when the infant naps. If she's working, parents can alternate responsibility for night or early morning feedings. When mothers are breastfeeding, fathers can change the diaper, bring the infant to the mother for night feedings, and settle the infant back in bed when the feeding is finished. This allows the mother more time to sleep and lets the father share the middle of the night care. Infant sleep patterns. Although many newborns sleep 16 to 17 hours per day, there is wide variation in the amount of time infants spend sleeping. Infants sleep less deeply than adults and spend 50% of their sleep time in rapid eye movement REM sleep. During this type of sleep, they sometimes make noises loud enough to wake parents in the same room. and they move about as if awakening. Going to them at this time is likely to wake them, but they may return to quiet sleep if left alone. Infants should be positioned on the back for sleep. The nurse should explain that the prone position has been associated with SIDS. No pillows or soft stuffed animals should be placed in the crib because they could cause suffocation. Sleeping through the night. Parents are often confused about when infants should sleep through the night. Newborns are not ready to sleep through the night during the early weeks of life because of their neurologic immaturity. By 12 weeks of age, many infants sleep at least 5 hours at night, and most infants sleep that long by 4 months. By 12 months of age, infants take 2 naps during the day and sleep about 10 hours at night. Once infants establish longer sleep patterns, they often awaken at night again when they are teething or ill. Therefore, parents can expect to be awakened frequently during the early years. Parents should be taught methods of helping their infants achieve longer sleep periods at night. Concerns of working mothers. Although it has been traditional for women who work to have at least 6 weeks of maternity leave, this is not always possible. Some women must return to work as early as 3 weeks after childbirth. The problems of working mothers are different from those of mothers who remain at home. They must find adequate childcare, identify methods of managing the household, and try to find enough time and energy to meet the needs of the infant, other family members, and themselves. Working mothers should not become so involved in their many responsibilities that they have little time for their own needs. Some mothers regularly schedule time for themselves and for family activities. Many working mothers find that the time they can spend with their infant is particularly precious. Concerns of adoptive parents. Although adoptive parents have not experienced pregnancy and childbirth, they must make many of the same adjustments made by biologic parents. In some cases, adoptive parents meet the biological mother during pregnancy and may even be with her during the birth. Other adoptive parents receive a call after months of waiting to be told that their new infant is ready for them. In both cases, the lives of the adoptive parents change abruptly. In some agencies, adoptive parents receive the same teaching given to biologic parents. However, their ability to absorb information may be impaired by the excitement of the situation. Although adoptive mothers have not been pregnant or undergone childbirth, they are still tired from the loss of sleep and sudden changes they experience. This may be surprising and worrisome to some. They may have many questions that nurses can answer. These parents need reassurance and emotional support as they experience this happy but exhausting time in their lives. Common questions and concerns. Dressing and warmth. The infant should be dressed as the parents would like to be dressed, with a receiving blanket added. The abdomen should be checked to see if the infant is warm enough. The infant's hands and feet may be slightly cooler than the rest of the body, but should not be mottled or blue. The infant's head should be kept warm because many thermal skin sensors are located in the scalp. A hat is appropriate if the infant is outside when it is cold or windy. Stool and voiding patterns. Formula-fed infants generally pass at least one stool each day. Breastfed infants may pass a stool after every feeding, or occasionally in the older infant, only one stool every 2 to 3 days. Infants may get red in the face and appear to be straining when having a bowel movement, but this is normal behavior and does not indicate constipation. Stools that are dry, hard, and marble-like indicate constipation. Watery stools indicate diarrhea. A watery stool is absorbed into the diaper with little or no solid material left at the surface. A water ring remains on the diaper, showing where the liquid was absorbed. Diarrheal stools occur more frequently when compared with the infant's normal stool pattern and are greenish from bile moving quickly through the intestines. Diarrhea can be serious because life-threatening dehydration develops rapidly. Infants should be taken to the pediatrician or nurse practitioner for treatment. The infant should have at least 6 wet diapers by the 6th day of life. If there are fewer voidings, feedings should be assessed. The mother should be nursing 8 to 12 times daily, and the formula-fed infant should be fed 6 to 8 times each day. Smoking. Many mothers quit smoking before or during pregnancy, but may not realize that preventing infant exposure to smoke is just as important after birth as before. Infants exposed to smoke from parents' cigarettes are more likely to develop frequent respiratory tract problems. Parental smoking is a risk factor in SIDS. Smoke absorption by infants occurs even when smoking is done in another room. Parents who continue to smoke should do so outside the house and away from the infant. Eyes. Parents can remove small amounts of mucus that accumulate in the corner of the eyes with a damp, clean washcloth, using a separate section for each eye. A large amount of mucus, redness, or excessive tearing indicates an infection or a blocked lacrimal duct. The infant should be seen by a pediatrician or nurse practitioner. Transient strabismus, misalignment or deviation of one or both eyes, is sometimes called crossing of the eyes. Although the condition is normal for the first 2 to 3 months, it can be frightening to parents. The nurse should reassure them that it will end after the first few months, when the infant gains control of the small muscles of the eye. It does not indicate that the infant will have later problems. Strabismus that continues after 4 months should be evaluated by an ophthalmologist. Baths. Bathing, cord care, and care of the circumcision site are discussed earlier. If the infant is washed well at diaper changes, and when milk is regurgitated, bathing the child every day is not necessary. Bathing should be a time for infant stimulation and parent-infant interaction. It can be done at any time of the day that is convenient for parents. Nails. Nails should be cut straight across with either blunt end scissors or clippers. Pressing down on the skin at the fingertip makes it easier to avoid cutting the skin. Nail edges can be carefully smoothed with an emery board. Some mothers prefer to cut nails while the infant is sleeping. Others have someone else hold the baby's hand steady while cutting nails. Nails grow rapidly and may need trimming once a week. Sucking needs. Parents often have questions about pacifiers and thumb sucking or finger sucking. All infants have an urge to suck, although the amount of sucking needed varies with individual infants. Some infants seem satisfied by feeding, but others suck their fingers or a pacifier, even when not hungry. The AAP recommends the use of pacifiers for sleep to help prevent SIDS. Use may be delayed until 1 month in breastfeeding infants. Parents may be concerned that sucking on a pacifier or thumb will cause the teeth to become maloccluded. The nurse should reassure them that sucking that is not all day long, or on an upside-down pacifier, and that ends before the secondary teeth begin to erupt, is unlikely to cause malocclusion. In some infants, non-nutritive sucking increases because the time they spend sucking during feedings is too short. Breastfed infants should be allowed to continue sucking at the breast long enough to meet basic sucking needs. A short time of sucking after the end of feeding generally satisfies the infant's sucking needs and increases production of milk. For formula-fed infants, bottle nipples should have small holes and be replaced every couple of months before they get soft. When infants use a pacifier, parents should be instructed to examine it often to see if it is in good condition. Cracked, torn, or sticky nipples, or nipples that can be pulled away from the shield, should be discarded. Pacifiers should be replaced every month or two because they may come apart as they deteriorate and cause aspiration of parts. The shield on the pacifier should be large enough that it cannot be pulled into the mouth. Pacifiers should not have any decorations that might come off and cause a choking hazard. Pacifiers should be kept clean by frequent washing, and parents should buy several so that a clean one is always available when needed. Pacifiers should never be placed on a string around the infant's neck. The string could become tangled tightly around the neck and cause strangulation. Clips with a short band to attach pacifiers to the infant's clothing without danger are available, or several pacifiers can be placed in the bed for the infant to find. Some parents find that one advantage of pacifier use is that the infant gives it up more quickly than a thumb or a finger because it is not so easily accessible. Parents who resort to the use of a pacifier as the first response when the infant is fussy are likely to reinforce its use and increase dependence on it. Pacifiers used only after other causes of distress are ruled out may be given up sooner by the infant. Because the need for non-nutritive sucking begins to diminish between 4 and 6 months of age, pacifier use may begin to decrease at that time with parents' help. Common rashes. Diaper rash. Diaper dermatitis. Diaper rash occurs as a result of prolonged exposure of skin to wetness, urine, feces, and friction against the diaper. A rash is more likely to develop when infants begin to sleep for longer periods and the time between diaper changes increases. Another cause may be sensitivity to commercial disposable wipes or components of paper diapers. Diaper rash is primarily treated by keeping the diaper area clean and dry. The nurse should instruct the parents to change diapers as soon as they are wet or soiled. They should gently wash the perineum with mild soap and warm water, but should avoid excessive washing or scrubbing. If commercial wipes are used, they should be free of alcohol, perfumes, or preservatives. Removing the diapers and exposing the perineum to warm air helps healing. Applying a thin layer of zinc oxide or petroleum may speed healing and help prevent recurrence. Vigorous rubbing to remove the skin barrier product is not necessary. Gentle cleansing to remove the soiled layer of barrier in the skin folds is adequate. Low-potency corticosteroid preparations may be necessary for severe cases. Talc-based powders should not be used because they can cause pneumonia if they get into the infant's lungs. Secondary infection of diaper rash with organisms such as Candida albicans or Staphylococcus is common. When infection occurs, severe rash, pustules, or crusted areas may appear. The infant should be taken to a pediatrician or nurse practitioner for treatment. Antifungal or antibiotic creams may be necessary for infections. Miliaria, prickly heat. Although most common during hot weather, miliaria, or prickly heat, develops in infants who are too warmly dressed in any weather. It may also occur in infants with a fever. This rash results from occlusion and inflammation of the sweat eccrine glands. It has a red base with papules or clear vesicles in the center. Treatment involves cooling the infant by removing excess clothing or by giving a soothing, lukewarm bath. The condition clears quickly with removal of the cause, and ointments or other skin preparations should be avoided. The nurse should discuss the appropriate amount of clothing with parents when infants develop prickly heat. Seborrheic dermatitis, cradle cap. Seborrheic dermatitis is a chronic inflammation of the scalp or other areas of the skin characterized by yellow, scaly, oily lesions. It sometimes results when parents do not wash the anterior fontanelle for fear that they will hurt the infant. Treatment is application of oil or shampoo to the area to help the lesions soften, and then removal with a comb or soft brush before shampooing the head. The nurse should teach parents how to shampoo the scalp and explain that they will not injure the fontanelle by normal, gentle shampooing. The scalp should be rinsed well to remove all soap, which otherwise may cause irritation. A persistent problem may be treated with hydrocortisone cream or special shampoos recommended by the pediatrician or nurse practitioner. Feeding concerns. Breastfeeding, formula feeding, and weaning are discussed in Chapter 22. This section addresses only regurgitation and introduction of solid foods. Regurgitation. Infants often regurgitate, spit up, because they may eat more than the stomach can easily hold, and because the immature lower esophageal sphincter allows the stomach contents to flow into the esophagus easily. Wet burps result when air is trapped under the stomach contents. As the air is expelled, a small amount of milk comes with it. The nurse should teach parents to differentiate normal spitting up from vomiting, which is a sign of illness. Regurgitation may occur frequently, but is usually only a small amount at a time. Vomiting may involve the entire feeding, and it is expelled forcefully. Parents should always seek treatment for the infant with projectile vomiting, in which the vomitus is expelled with such force that it travels some distance. If an infant has frequent regurgitation, place the infant in a more upright position during and for a short time after feedings. Small, more frequent feedings also may help. Some infants swallow excessive air because they feed rapidly. Nurses can instruct parents to feed infants before they get too hungry and to stop often for burping. If the hole in a bottle nipple is too small, an infant may swallow the air around the nipple. Enlarging the nipple hole slightly with a hot needle may prevent this. The hole should not be too big, or the flow of milk may be too fast and cause choking. The infant who has excessive regurgitation or vomiting should be referred for follow-up with the pediatrician or nurse practitioner. Introduction of solid foods. Infants do not need solid foods until 6 months of age. It is recommended that infants should have only breast milk for the first 6 months. Some mothers introduce solids earlier in the hope that the infant will sleep longer at night. This is seldom successful because the infant receives no more calories from the small amounts of solids taken than from breast milk or formula. When infants are started on solids, they drink less milk, thus replacing a food that meets their nutrient needs well with a food that is poorly digested. The extrusion reflex, in which infants push the tongue out against anything that touches it, continues until approximately 4 to 6 months of age. This makes feeding a younger infant difficult because the infant pushes almost all of every spoonful out of the mouth. The nurse should explain the problems involved with early introduction of solid foods and encourage parents to wait until the infant is physiologically ready at 6 months of age. The concerns that made the parents consider changing the feeding routine should also be discussed. Growth and development. Anticipatory guidance. Parents often have questions about normal patterns of growth and stages of development. Nurses provide anticipatory guidance about these areas to help parents develop realistic expectations about infants' abilities at various ages. Growth and developmental milestones. A brief summary of the changes that can be expected during the infant's first 12 weeks is included here. More in-depth information is found in pediatrics textbooks. The nurse should emphasize to parents that guidelines are only averages. The range of normal is often broad, and individual differences are expected. Growth proceeds at a predictable rate in normal infants. The weight lost after birth is usually regained by 14 days of age. In the first 3 months, the average infant gains approximately 1 ounce, 30 grams, each day, and 2 pounds, 0.9 kilograms, per month. Each month, they grow 1.4 inches, 3.5 centimeters, and have an increase in head circumference of 0.8 inch, 2 centimeters. The posterior fontanelle closes by 2 months, and the anterior fontanelle by 18 months of age. Tears are scant or absent for the first 2 months of life. Parents are especially interested in the Moro, grasp, and rooting reflexes. The nurse should point out that their gradual disappearance helps prepare the infant to learn new skills, such as voluntary grasping or turning over, which are impossible if the reflexes continue. The infant gradually develops more control of the heavy head and has less bobbing or head lag by the end of the third month. Infants are social beings. They stare at objects of interest and focus best within a range of 8 to 12 inches, 20 to 30 centimeters, as newborns. By 3 months, infants can follow interesting objects horizontally across the midline. A social smile begins at 1 to 3 months. Infants start making vowel sounds, cooing, at 1 to 4 months and laugh at 3 to 6 months. Accident prevention. Knowing what infants can do helps prevent accidents. In the first 3 months after birth, they are totally helpless. Although they can communicate their needs through crying, someone must be available at all times to care for them. Parents should be taught the dangers of leaving the infant on any unprotected surface, even for seconds. In a short time, an infant can wiggle from the middle to the edge of a large bed and fall. If parents must turn away, they should keep one hand on an infant lying on an unprotected surface. Infants should never be left, even for an instant, in even 1 inch of water because of the danger of drowning. Parents should turn the telephone off or take it with them and ignore the doorbell while bathing the infant. If they must leave the room, parents should take the infant out of the water and with them. As infants learn to grasp objects with increasing accuracy, 4 months, parents should be certain that nothing that could be swallowed or otherwise cause harm is within the infant's reach. Help parents think ahead to the time when the infant will be crawling and walking and make plans for how they will child-proof their home. Well baby care. Well baby checkups. Well baby checkups are an opportunity for the pediatrician or nurse practitioner to assess the infant's growth and development, answer questions about feeding and infant care, observe for abnormalities, and give immunizations. These checkups may be provided by a private practitioner or in a well baby clinic where examinations and immunizations are free or at reduced cost. Infants are usually taken to their first checkup between 48 hours to 2 weeks after discharge from the birth facility. They generally receive well baby checkups at 1, 2, 4, 6, 9, and 12 months of age. Anticipatory guidance is a major part of well baby visits. Safety is discussed as parents are taught about skills infants will soon develop that might place them in danger. Immunizations. Nurses often receive questions about the need for immunizations for uncommon diseases, such as diphtheria, that parents have never seen. Parents may consider a condition such as varicella chickenpox to be a harmless childhood illness. When they do not understand the need for immunizations, parents may be reluctant to have their infants undergo painful procedures. The nurse should explain to the parents the importance of immunizations, briefly describing the serious illnesses that are prevented by immunizations. Discuss the age at which each immunization is given and when boosters are needed. Because recommendations for immunizations change from time to time, parents should be referred to their pediatrician for the latest information. Another source is the AAP website, which offers information for parents as well as for professionals. In the United States, national health objectives for the year 2020 include achieving and maintaining effective vaccination coverage levels for universally recommended vaccines among young children with targets of 85 to 90%, depending on the vaccine. Maintaining a high level of immunization is important to prevent the rise of communicable diseases, as has happened in the past when a resurgence of measles occurred in many U.S. communities. Illness. Parents have many questions about illnesses in the infants. They have concerns about how to recognize an illness and when to call the pediatrician or nurse practitioner. Recognizing signs. Parents may need help in recognizing signs of illness in infants. The nurse should explain that any time the infant appears sick or parents think something is wrong with the infant, they should call the pediatrician or nurse practitioner. Office staff is usually educated to help parents determine whether the infant is sick enough to need an appointment. Calling the pediatrician or nurse practitioner. When calling the healthcare provider about an illness, parents should prepare by writing down the information about the illness to avoid forgetting something. They should have the name and telephone number of a pharmacy available in case a prescription drug is needed, and they should be ready to write down instructions. Office staff members are usually able to answer questions on the telephone about common concerns and simple illnesses. They can help determine whether an infant should be seen by the healthcare provider, but parents should be assertive in asking for an appointment if they believe that one is needed. Parents should immediately identify emergencies so that the staff can act accordingly. Knowing when to seek immediate help. Parents should take the infant to the pediatrician or to a hospital if signs of dyspnea are present. An infant from birth to 3 months of age should not have a sustained respiratory rate above 60 breaths per minute. If retractions, cyanosis, or extreme pallor is present, parents should get immediate help. If respiratory difficulty occurs suddenly in an infant who is well, the infant may have aspirated a feeding or small object. Parents should call the emergency medical services. Nurses should encourage all parents to take classes in cardiopulmonary resuscitation. If an infant's respiratory rate is below 30 breaths per minute, parents should stimulate the infant and see if the respirations increase and stay within the normal range of 30 to 60 breaths per minute. If the respiratory rate continues to be below normal, the infant should be seen by a pediatrician, by a nurse practitioner, or at a hospital. Parents should call the pediatrician if the infant is hard to arouse and keep awake. The infant could be semi-comatose and showing signs of a central nervous system disease such as meningitis or encephalitis. Learning about sudden infant death syndrome. Sudden infant death syndrome, SIDS, is the abrupt death of an infant younger than 1 year of age that is unexplained by history, autopsy, or examination of the scene of death. In the United States, approximately 2,250 infants die of SIDS each year. It is the third leading cause of death in infants from birth to 1 year of age and the most common cause of death in infants from 1 month to 1 year of age. SIDS occurs in apparently healthy infants during sleep and more often in male infants. It peaks in infants who are 2 to 3 months of age, and 90% of SIDS cases occur before 6 months of age. African American, American Indian, and Alaska Native infants are 2 to 3 times more likely to have SIDS. The incidence is lower in Asian, Pacific Islander, and Hispanic infants. There have been many studies, but the cause of SIDS remains unknown. Sleeping in the prone position, sleeping on a soft surface, overheating, maternal smoking or drug use during or after pregnancy, young maternal age, low socioeconomic status, late or no prenatal care, prematurity, low birth weight, and male gender, and prenatal exposure to nicotine, alcohol, and illicit drugs have been associated with SIDS. Risk for SIDS is increased when infants sleep in the same bed with another person, on adult beds or sofas, or with pillows, stuffed toys, or loose bedding, or become overheated during sleep. Bed sharing with a parent is controversial and not recommended at this time. The current AAP task force recommendation is that a healthy infant be placed in the supine position for sleep because the prone position may increase the risk for upper airway obstruction, rebreathing of expired air, and hyperthermia. A national goal for the year 2020 is to reduce the number of SIDS deaths by increasing to at least 75.9% the number of infants who are put to sleep on their backs. Approximately 20% of SIDS cases occur when the caregiver is not present. Parents should ensure that all caregivers of their child are aware of the risk associated with the prone position and follow the guidelines. Nurses should teach parents about the AAP recommendations for the supine position for sleep and give parents educational material about the position. It is important for nurses to model this behavior in addition to teaching about it. For suggestions on modifying some risk factors, see Patient Teaching, How to Help Prevent Sudden Infant Death Syndrome. Parents may be concerned about abnormalities in head shape that may occur in some infants from sleeping on the back. Flattening of the head may result from prolonged lying in the supine position. This can be prevented by the parents placing the infant in the prone position on a firm surface during awake periods several times a day while watching the infant. Parents should be taught the importance of tummy time to help develop the shoulder muscles as well as prevent plagiocephaly. The prone position helps the infant develop neck, shoulder, and arm muscles. Toys placed within reach can help infants focus and begin to reach for objects. The position also helps the infant attain developmental milestones such as rolling over and crawling. Infants tend to look toward the center of the room or the door when in their beds. Placing the infant at alternating ends of the crib often influences the direction of turning the head and distributes pressure more evenly. Avoiding prolonged time in car seats or other seats and holding the baby in an upright position some of the time may also help. Infants who develop flattening of the head should spend very little time in infant seats, swings, or car seats because these put pressure on the back of the head. Because parents often have many concerns about SIDS, therapeutic communication techniques may assist them to talk about their fears. They may need reassurance that the chance that any one infant will experience SIDS is small. When parents have experienced loss of an infant from SIDS, they need appropriate counseling. One organization that provides this is First Candle.